a little more out of the physicians. We're also being hit with this Epic launch, and so I don't know how many of you are in the middle of this EMR struggle, but they're difficult things for us. But anyway, this talk is a 10-minute talk on who should be on the team for critical limb ischemia. Here's my disclosures. I don't think anything really relevant to this. So I backed up a little bit before I tell you who's on the team and just say, what are our goals here? Basically, our goals are, with mostly a diabetic population, to prevent limb loss. That's really the goal. And then how do we prevent that? And I think when you back into who's on the team, you got to figure out what is it that we assess. Clearly, one issue is diagnosis. You really need to have good skills, either your own team or an excellent radiology team to look at imaging, because really we find getting into the cath lab is at the end of the game here. Clearly bedside ABIs we've actually taken out into our peripheral clinics. A lot of these PadNet services where we're just looking at ABIs, getting some simple numbers from our primary care groups, and then taking that further, probably the next step for most of us is duplex imaging, which if you really have a good imaging team, you really can get a lot of information non-invasively. And then from that you move into either MRA or CT, and really CT and MRI are so accurate these days, you can get a lot of information before you ever need to go to the cath lab. So anyway, people who would make a good diagnosis are critical. I think highlighted in yellow are the key things for us in the periphery, and that is really ABIs with our primary care groups, for them to assess things, followed by duplex. The other thing that we've done in our wound healing centers or wound clinics has been TCPO2 levels, trying to predict who can actually heal their wound, and I'll get into that in a second. But two major issues here. The national guidelines currently indicate that you need to rule out arterial disease by assessing ABIs and toe brachial indices with anybody who's got an ulcer in the lower extremity. And actually the guidelines for the American Diabetic Association suggest that all diabetics over the age of 50 should have a screen for PAD. And so these are things that if you bring up to the primary care groups who feed you business, it really does expand the base of the pyramid, so you can catch people earlier before they get advanced disease. For us, I think ultrasound is key. You can do so many things with duplex. You clearly can make a diagnosis. You can get an anatomical location. You can define where the stenosis is and select what candidates might be appropriate for an endovascular or an open procedure. And then CW Doppler, I think, is also helpful for looking at patients who have poorly compressible vessels or assessing things quantitatively once you've revascularized over time. And then the other thing that I've learned a lot about is TCPO2 with our wound healing center and predictors of who is going to do well. We really worry about patients who have TCPO2s below 50. Anybody really below 40, we think there's very difficult for them to heal the wound without some improvement in arterial inflow. And so these are the patients that our wound healing centers are really concentrating on to get an arterial assessment. So for us, basic treatment maintains good primary care and diabetic care with things like aspirin, ACE inhibitors, statins, Plavix, possibly Platol, adequate pain control for those who have big open ulcers, and then finally management of the ulcer and or the gangrene with aggressive control of infection, local therapy with debridement, which is our surgical colleagues help us with, and relief of pressure. And then revascularization, obviously, predominantly endovascular really, and amputation when you need it. And so I think